Good evening, everyone. Thank you all for taking the time to come out tonight for what promises to be a very informative evening, and welcome to 2014 and beyond. What will your healthcare plan look like? Tonight's public information session is co-hosted by the Memorial Hospital and the Mount Washington Valley Chamber of Commerce as a service to our citizens and the business community. My name is Tad Furtado. I'm on the board of directors of the Chamber of Commerce, and I chair the newly created Public Affairs and Advocacy Committee. I'm also co-owner of Conway Family Dental Care, which is a dental practice based here in Conway. In a previous life, I served as Chief Policy Advisor to U.S. Representative Charles Bass and the House Energy and Commerce Committee, which has primary jurisdiction over the nation's healthcare laws. Before we begin, let me take a few moments to do some housekeeping. The restrooms are located just, I think, outside the doors off to the left here if you need them. Please note that we have chosen a group of healthy food options for your enjoyment, and that we'll be choosing the winners of our Healthy Living giveaway at the end of the evening. And finally, be advised that Valley Vision is here taping tonight's session, and that other members of the press may be in attendance.
So behave.
So behave, exactly. In March 2010, Congress passed and President Obama signed the Comprehensive Reform, Patient Protection, and Affordable Care Act into law. As you know, enrollment for one of the law's key elements begins on October 1 of this year, which is less than 4 weeks from yesterday. We're pleased to have our 4 panelists here tonight to provide insight into what may be our best course of action to navigate the Affordable Care Act. Each panelist will be given time to share information within their subject matter expertise, and at the end of the presentation, after they're all done, we'll take questions from the audience. So, again, it's my pleasure to introduce and welcome Scott McKinnon, CEO of Memorial Hospital since 2009. Mr. McKinnon is active on several local community boards and was recently named board president of the Mount Washington Valley Economic Council. At the state level, he chairs the Rural Health Coalition and is also on the boards of the New Hampshire Hospital Association and the Foundation for Healthy Communities. He'll kick off tonight's program with the Affordable Care Act and what it means to healthcare providers and facilities. Then we'll hear from Greta Johansson of the U.S. Small Business Administration State Office. Ms. Johansson leads the state's SBA team in delivering their programs and services throughout New Hampshire. She works with lenders, SBA resource partners, economic development entities, and others to foster entrepreneurship and business growth. She became New Hampshire's district director in 2011 after previously served as the deputy director in Connecticut. Then we'll hear from Susan Ticehurst, who was elected to her first term last year. The 3rd district, which she serves, includes the towns of Albany, Madison, Tamworth, and Freedom. She's a member of the House Committee on Health, Human Services, and Elderly Affairs. And then finally, we'll hear from Deb Fournier, who is a policy analyst with the New Hampshire Fiscal Policy Institute, which is a private nonprofit based in Concord. Deb previously served as a senior policy analyst for federal and national affairs in Massachusetts Office of Medicaid. Yes, the volume just went out. Everyone in the back, hear me all right? Was it a problem before? All right, I guess it was a problem before. Everything, right. I'll hand them copies later. Deb holds law degrees from a law degree, I assume just one. 3 years was enough. From Northeastern University School of Law and is a licensed attorney. So welcome to each of you, and thank you for being here tonight. The format tonight, as I mentioned, will be to give each panelist 15 minutes to share their expertise with us. For you all, for our neighbors and others here tonight, there are pads and pens on the table for you to use for notes, and also maybe to jot down some questions you may have for our panelists when we get to the Q&A at the end. Tonight's event is intended to inform us about the significant changes that are in store for us. These are going to happen. So I'll caution that it is not an evening for political debate. Questions along that line just won't be entertained. Otherwise, this can be a confusing topic, so there is no question that is too silly. Shall we begin? Great. So, Scott, you're up. No, I think we're good.
Thank you, Ted. Good evening and welcome. I'm actually very pleased to be here and glad that Memorial Hospital could co-sponsor this event. I'm really going to share with you my perspective on, as mentioned in the introductory comments, really the impact from the provider's perspective, and talk a little bit about what Memorial Hospital is doing with its partners in the community on how we're preparing and positioning the organization. And even though the title is around the Affordable Care Act, I look at it in a little bit broader sense in terms of healthcare reform. And obviously the Affordable Care Act is a critical piece of legislation that supports healthcare reform. Healthcare reform itself has been going on for many, many years. Significant legislation in the 60s called Medicare was introduced. In the 80s, we saw the introduction of legislation for what was referred to as diagnostic-related groups. That was a very different way, in a prospective way, that hospitals were reimbursed for their inpatient care services. So reform is something that is continuous, but obviously it's been highly escalated as of 2010 with the signing of the Affordable Care Act. But again, I really, from a hospital's perspective, look at how we approach from really that triangle approach of the three, what I see are the key elements of healthcare reform and the Affordable Care Act, and that's around access, quality, and affordability. And so I kind of came on board at about the time the new act was signed, and we've been doing a lot of different things in order to position the hospital for the future so that we can effectively serve the needs of the community going forward. Let me talk just for a moment about access, because really when you talk about what's right in front of us in terms of potential Medicaid expansion, healthcare exchanges, mandated insurance, that's going to have potential immediate impact on that whole issue of access. Carroll County has a very high percentage of uninsured individuals. The state of New Hampshire is a fairly significant number, and then you can look at what folks that do utilize the hospital services. There are a fair amount, about 10% of folks that utilize the hospital services are uninsured. And what's going to happen with these different legislative acts in terms of what will we see in terms of insurance coverage in the community? Will we see a surge? And I think a lot of providers of healthcare services are asking the same question. And now, today, uninsured folks still, they can receive care and access through a lot of different avenues, but with increased insurance coverage, you may see a surge of what we think we'll see in terms of people accessing primary care services, preventive health care services, which is a good thing. Because a lot of times now you'll see with the uninsured population that the care setting may potentially be in the emergency department, which is not the best setting for primary care services, or it may be in the emergency department after they haven't received the adequate preventive and primary care and are now in a higher acute state of some level of chronic disease or illness and require emergency care services. So part of what we've been really doing is looking at our provider and our service models to be sure that we're in a good place to have the primary care services available and accessible to our current folks and any new folks that might gain coverage under this. So what does that mean? It's everything from facility design, where we've expanded our emergency department to add an express care component to be able to more efficiently treat people with lower acuity disease. We've also done some remodeling of our primary care offices, so it creates a more open workplace concept, more efficient flow to support a new model of what we're putting in primary care, and it's referred to as clinical care teams, and ultimately leading to what we refer to as a medical home concept. And that's the name kind of says what it is. It's a medical home. It's a coordinated team of different providers, physicians, non-physician providers, nursing support staff that care for a component of the population of patients in a more efficient, coordinated fashion to be sure there's communication, there's better follow-up, there's better integration of health and wellness and screenings and preventive health. And so we've already put one of these clinical care teams in place, and we're getting ready to put our second clinical care team in place. So we think this is a better model to help meet the needs of folks that are going to be needing to get good primary and preventive health care services. Another thing that's important in terms of seeing potential surges in folks accessing primary care services, if you look at provider capacity, physicians, other advanced practitioners, and you look at the population demands and needs that are going to be going forward, there's actually a very significant shortage in the pipeline of people that are training to enter these professions, particularly with the physicians. And being in a rural health environment, that's stressed a little bit more because of the difficulty in recruiting providers into a rural area. what I think what all organizations will see is more dependency and creation of models that use other healthcare professionals in that preventive care model, such as I mentioned with that clinical care team, utilizing advanced nurse practitioners, physician assistants who can very effectively serve as a key access point and link in primary care services in a critical component of these clinical care teams. And so part of what we're doing is restructuring and looking at our recruitment models so that we're also recruiting these other trained professionals of the non-physician providers. And we currently use a lot of these skilled providers, whether it's advanced nurse practitioners, the midwives we use in our OBGYN services, our nurse anesthetists, and our ORs, physician assistants in some of our specialty practices. So already, being in a rural area, this is a very collegial model and a very professional model that's been very successful for us. And we see that there's going to be a higher need to create these models so that there is enough access to receive these professional services. So part of it, preparing for what's coming down the pike in front of us in terms of the mandate insurance and the potential Medicaid expansion, more people accessing primary care. We're revamping our coverage models and even down to our facility design so that we're in a different place for this. Now, a lot of this discussion tonight is also about navigation of the system, and there's still a fair amount of confusion out there on what this means and how do I receive the coverage and access and that I need going forward. One of the things that we'll be doing at the hospital is we're revamping our financial services model so that we'll actually have frontline people in these financial counseling positions that will be available to help people navigate the services at Memorial Hospital and beyond the walls of Memorial Hospital and provide vital information, whether it's for obtaining insurance, healthcare assistance, or getting appointments within the different primary care and specialty care areas. So the new healthcare reform, Affordable Care Act is really relying on us to make sure that we're very proactive on the front end so that we have these people in our financial division that can serve as these navigators to help people from the hospital's perspective to help them receive the care that they need going forward. I wanted to move a little bit to one of the other arms of quality, and in looking at the Affordable Care Act going forward, there are also a lot of, basically the whole environment ultimately is positioned to shift from a volume-driven fee-for-service model for hospital services to one that's more dependent and incentivized on prevention, quality outcomes, and metrics. And in the future, that's how providers are going to be incentivized for providing healthcare services. And through the Affordable Care Act, this has already begun in certain instances. There are already demonstration projects that have begun almost a year ago in some of the larger PPS or prospective payment hospital systems that are running programs through Medicare now that are providing incentive or decentive, not just on how many procedures they do, but on the quality outcomes and meeting certain quality metrics and criteria. So those programs are already in place and being trialed, and that will just continue, I think, to push forward. Now, being a very rural critical access hospital, our timeline's a little bit different. We'll probably see somewhere further down the line in the next few years that will be required to meet that criteria. Also, a lot is just because we don't have the same volume that generates these outcomes that some of the larger providers do. But regardless of that, we've already begun we've already restructured our quality services and how our quality department on preparing for moving into this new era when we're going to be really measured on the quality of our outcomes, not just on the volume of our outcomes. And so we've really developed internally a structure that focuses around key metrics of safety and quality. We have what we refer to as our strategic aim goals, where we set targets on where we need to be, whether it's clinical outcomes, infection rates, readmission rates, or whether it's patient service metrics on how well we're perceived and graded by our community and how well we're delivering care. And we've already put this as the emphasis in the forefront on what we need to be driving towards, because that's what the future is going to hold, that we're required to submit to CMS our different outcomes around these key clinical quality and service outcomes, and that's how organizations in the future are going to be measured and how they're going to be incentivized. So we're doing a lot within our quality programs to assure that we're up to meet the needs of where we need to be in the future. In addition to that, information sharing is vital to coordination, quality with these different healthcare outcomes. And part of that goes to, you hear a lot about hospitals investing a lot of resources into their electronic health record systems, of which we have a few different health records at the hospital. But what we're doing is part of the value of our relationship that we're pursuing with Maine Health is allows us to advance forward into that by allowing us to get one single system that will be one patient, one record, not just here in the valley and at the hospital, but over into Maine with our tertiary partner, Maine Medical Center and Maine Health, so that people will have a better coordination and access and communication of information, healthcare information, which is a huge component of the quality outcomes. So there's a lot of different things we're doing through our partnership with Maine Health, through our local efforts around driving our quality outcomes and metrics at the hospital, and then also collaborative relationships that we've engaged in here in the community. You know, the hospital isn't the only healthcare provider in this community. And about 3 years ago, we formed what we refer to as our healthcare council, which basically is representation from a vast array of different providers in the valley, which includes Memorial Hospital, includes Saco River, includes White Mountain Community Health Center, includes VNS and home health care, it includes the mental health services. I hope I didn't forget someone out there, but it's basically all the folks that are providing care along the continuum. And we've begun working together on how we better transition and coordinate what we refer to as care transitions throughout the community. So, you know, if a patient needs, for instance, a joint replacement procedure, that's just not reliant on the OR and the post-acute care at the hospital. They may need home health care, or at Mineral Springs, they may need some level of rehab care, inpatient rehab care. And we're working together to better coordinate how we care transition throughout the community. Because again, in the future, that's going to be how organizations, healthcare providers are going to be measured and incentivized on how well they deliver episodes of care. Another thing you'll see on the Affordable Care Act is what's referred to as bundled payments. And what that means, you know, in today's world, it's each provider is basically generating a fee for whatever specific service that is. In the future, what we'll see, and again, these are getting ready to begin in demonstration products, is that an episode is paid a bundled payment to a group of providers to share amongst themselves based on providing an episode of care throughout that whole care continuum, similar to the example I just talked about in terms of a orthopedic procedure. So we're also working on a lot of healthcare prevention models that we can work well together, working on obesity programs, diabetes, a whole host of different things that really cross over a lot of the different care continuums, and how can we better work as a group of providers in the community to provide quality care throughout that, as opposed to working just in our individual silos. And I think we've made a lot of progress, and we have a lot of energy in that group, and we're making a lot of progress. Again, with collaborative relationships are going to be important in the future. Again, with the Affordable Care Act and healthcare reform, heavy emphasis on wellness, prevention, partnership with Maine Health allows us and gives us access to a lot of resources to help develop education, prevention, and wellness programs in the community. We'll be doing a lot of that over the next several years. So again, on that second arm, a lot that we're doing in terms of quality to meet the requirements of what are to be required in the future. And then the last of the three pillars is what I refer to as affordability. And I think it's pretty well known in the healthcare provider industry that reimbursement will continue to go down as healthcare is expensive in this country, and there's a lot of focus via the Affordable Care Act and healthcare reform to make healthcare more affordable. And that's everybody that's in the healthcare arena, including the providers and the acute care providers. Reimbursement will continue to go down. Right now, a lot of hospitals, particularly rural ones that provide a lot of uncompensated care, rely a lot on what's called disproportionate share payments to help offset the cost of providing healthcare services for the under and uninsured. That is eventually going to be reduced and go away to a certain degree, because the theory behind the Affordable Care Act is that the majority of people will now have health care insurance. But even with that said, the reimbursement levels will continue to decrease. So the hospital, all hospitals are going to be required to look for more opportunities to reduce their expenses. Some of that's done internally through our internal efforts on how we can do things more efficiently. We've done a lot over the last few years at Memorial Hospital on looking at different types of methodologies, lean processes, how we can find more efficient ways, which not only reduces costs, but improves the quality and the outcomes of what we're doing. So there's the internal component. Again, back to collaborative relationships. If we're working well with our partners in the community, can we do it more effectively and more efficiently than we're all doing it individual components? Same thing with the Maine Health relationship. You know, part of becoming part of that organization gives us the opportunity to access and reduce our cost in a lot of key areas, particularly around administrative costs, legal costs, supply chain costs. We see a lot of opportunity to help reduce our costs at the hospital to make us more efficient, because healthcare reform, through decreased reimbursement, through payment reform, is going to put a lot of pressure on organizations to become more efficient and reduce their costs. You'll hear a lot about a term called an accountable care organization, and there's also demonstration projects. That's also part of the Affordable Care Act, and there's demonstration projects on the forming of these organizations, which are physician groups with provider partners that care for a segment of the population, and they're incentivized and driven by creating clinical and integrated efficiencies and being their success measured on the healthcare and quality outcomes they have, as opposed to the traditional model of fee-for-service. Part of the relationship with Maine Health allows us to be part of one of these accountable care organizations. Right now, the way that the accountable care organizations are defined, we're not large enough to be our own accountable care organization, but by the relationship with Maine Health, we'll be able to participate in these models of accountable care organizations, which will give us the opportunity to get the benefits of becoming a more integrated, more efficient system in terms of how our provider referrals and those type of services are provided. So there's a lot going on, I think, in what I call kind of the triple aim approach. And there's a lot we've been doing over the last several years to really prepare for that. There's a lot of work ahead in terms of, a lot of these things are going to transition over many years. But I think we're laying the groundwork so that we can be sure that we're doing the job we need to be doing for our community, to be sure we're keeping, not just providing the essential healthcare services, but doing what we can to keep the community healthy. So thank you very much, and I'm going to pass it on to Greta.
Hello, good evening, everyone, and thanks to, can you hear me? It seems like the volume went down. Okay, it's very sensitive. Okay, good evening, thanks for being here. Thanks to our host, Memorial Hospital, and Janice with the Chamber. Appreciate the opportunity for you folks as well as for me to be a part of this. And as I'm with the Small Business Administration, our focus in the Education Forum here is on provisions of the Affordable Care Act that will impact businesses, our businesses. So I believe we have a fair number of businesses represented in the audience. Yes? That's a good number. Okay, I will do my best. There are regulations that are rolling out on almost a daily basis, but I want to touch on some of the things that we do know now and cover some of those components. There are different impacts and different components of the Affordable Care Act that may vary on how they impact the decision you need to make according to how many employees you have. So I'm going to touch on the subjects in that order. Sole proprietorships without other employees, those employers with fewer than 25 FTEs, and I'll define in a little bit what an FTE is for you. Those who have 50 or fewer FTEs, as well as those who have 50 or more FTEs. Different impacts according to where you are in those groups. And I'll also do my best to provide you with a list of resources that can help you find new information as it comes out and solidify some of what I'm going to touch on. I will be referring to the marketplace and shop quite often. What the marketplace is it's an access point. It's a place where information on different insurance insurance options for the individual and the small market can be found. It's housed at healthcare.gov. Marketplace is where the individual information is. Shop, S-H-O-P, is where the small business information is. So when I talk about the marketplace or shop, I'm simply talking about an access point where your insurance providers will be uploading information about the plans that they have available for those markets. And again, that's healthcare.gov, and that's a focal point for a lot of information about the Affordable Care Act. So beginning with sole proprietorships with no employees. From a marketplace perspective, that sole proprietors with no employees are treated in the marketplace as individuals. That means you go into the marketplace, you don't go to shop, you have the option of going into the marketplace as an individual to look at what your insurance options are. There are individual mandates that are effective come January 1. So when the marketplace opens on October 1st, it would be a good idea to check it out. There is an expectation that individuals will do their best to either acquire basic health insurance coverage or qualify for an exemption. And if you're not in one of those two categories, there's a possibility of a shared responsibility payment. There are resources for helping you acquire that insurance. If you already acquire insurance, if you already have a broker or an agent that you work with, you can certainly keep on continuing to work with that agent or a broker, or you can go directly to the marketplace. There will also be more educational resources rolling out. I'll be involved in a meeting on Friday as the state and federal partners work to do more outreach in the individual marketplace to bring that education and assistance to people through trained service providers who have received very specific training on how to help people navigate the marketplace. I mentioned that the anticipation is that people will either acquire insurance or qualify for an exemption. The final guidance on those exemptions has come out from the IRS. That has been issued. And there are a few where folks may fall into the exemptions. And they include such things as a low enough income that you're not in a position to even file a tax return, or a financial hardship, if you can justify the financial hardship. There are a few different things that could come up. There's an exemption for a religious prohibition. There's a variety of exemptions. And again, IRS.gov, if it involves tax credits or shared responsibility payments or any of those things, that information, the original source is going to be IRS.gov, and their Affordable Care Act information is pretty easy to find. But there are quite a few of those exemptions that you should look into. Absent an exception or health insurance, there are, beginning January 14, individual shared responsibility payments. Now, the shared responsibility payments can't really kick in until 2014 tax returns are filed, so we're looking at 2015 before the decision can be made about whether or not anyone owes one. But it is something to keep in mind so that you factor that into whatever decision you make. Initially, to start out with, in 2014, that shared responsibility payment is 1% of income or $95, whichever is higher. And there's incremental growth in the future years. There's an inclusion for covering uninsured, for a premium for uninsured children, and it increases each year. So factor that into whatever decision you make. There are also, if you're struggling with the cost of health insurance, there's also the possibility of premium tax credits. And to find out if you're eligible for a premium tax credit, you would have to go through the marketplace, go to the marketplace and fill out the information that will be available online, or work with one of the navigators that will be available to help you compile the information that you need to determine whether or not you would be eligible for a premium tax credit to help you offset the cost of acquiring health insurance that provides at least minimum value. Basically, the tax credits will be available for households earning somewhere between 100 and 400% of the federal poverty level. Now, that's adjusted on a regular basis, but in 2013, for a family of 4, that was an income ranging from $23,550 to $94,200. If you're somewhere in that range and the cost of acquiring insurance is going to be a bit of a stretch for you, then look into the premium tax credit option before you make that decision. And again, stuff rolls out on IRS.gov on a regular basis. So In the individual and the small marketplace right now, as of today anyway, Anthem Blue Cross Blue Shield is the only insurance provider who has signed in to offer health insurance through the marketplace and through SHOP to that market. Harvard Pilgrim has, I've heard a few different people from Harvard Pilgrim state specifically that they're looking to join in 2015 if possible, or at least by 2016. So there will hopefully be more choices in future years as this rolls out. Anthem being the only provider doesn't mean there's only going to be one choice of plans. Anthem can offer different choices in different tiers for different levels of coverage for different, that would result in different costs to the insured, different out-of-pocket costs, different premium costs. So we're just going to have to wait. That information will be live in the marketplace online at healthcare.gov beginning October 1. And until it goes live there, it's up to Anthem to decide whether or not they're going to disclose that information early. So that's their proprietary information, and there's not a whole lot else that we can do until it's available online. The next category of businesses that I want to speak to are those who have fewer than 25 FTEs. So let me explain what an FTE is first. Under the Affordable Care Act, determinations are made about employer-sponsored insurance based on full-time employees with a slightly different definition than most of us have ever thought full-time employees were. For the purposes of the Affordable Care Act, any employee that works on average 30 or more hours a week under this act is treated as a full-time employee. Below 30, part-time. 30 and up, full-time. And that's just for the purposes of this act. So we're looking at, on average, 30 hours a week, which is also on average 130 hours a month. So if you have fewer than 20, and I'm sorry, to get your FTE calculation, your first thing you do is you count up all of your employees that work on average 30 or more hours per week. That's your full-time count. To get what you add to that is if you have also part-time employees, you have a handful of employees, 5 employees, 25 employees who work fewer than 30 hours a week, then you go through, you add up all of their hours, you divide it by 120 and figure out what is that per month. I mean, that'll give you another number. You add up all of their monthly hours, all of their weekly hours, all of their annual hours. You do whatever. You look at those hours and you equate them to some smaller number of full-time equivalents. It would be nice and easy if we could just say, well, 2 15s is equal to 130, but it doesn't. It's close to that. If you're struggling with whether or not that part-time count is going to put you in the 50 or more category versus the under 50 category, feel free to check with me and I'll try to help you walk through the exercise. But okay, no buts there. Once you've gone through that count, then you've got your count of what we're calling FTEs, full-time equivalents. It's just the abbreviation that I'm going to use from this point forward is FTE. So if you've gone through that, you've checked all your hours, you've figured out your full-times and your part-times, and your FTE count is below 25, there's a possibility that you want to look into about tax credits that can help offset the cost of providing health insurance to your employees. The tax credit's been in effect since 2010. And so businesses have been receiving that tax credit since 2010. I saw a stat that says 360,000 businesses across the country. I do not know how many there are in New Hampshire, but I know there are some because I've heard them speak at different forums. So if you have fewer than 25 FTEs, the next thing to check is average wages. If the average wages among all of your employees is below 50,000, then the next thing to check is how much of the cost of insurance for a self-only plan are you contributing. If you're contributing 50% or more of that cost, or if you would like to contribute 50% or more of that cost, then look into the tax credit because it may help offset that cost for you. The tax credit for for-profit businesses since 2010 has been at 35%, and that's a direct tax credit to help offset the cost. The tax credit also applies to not-for-profit organizations, and since 2010, it's been at 25. That increases, those tax credits increase in 2014 if you shop for the insurance that you're acquiring through the marketplace, through SHOP, and all those other conditions are met, fewer than 25 employees, average wages below 50,000, and you're going to contribute at least 50% of the cost of the coverage. then the tax credit for for-profit businesses is increasing to up to 50%, and for not-for-profits up to 35%. It's a sliding scale, so the fewer number of employees you have, or the lower the wage level is, the higher the credit may be. But it's a sliding scale from 0 to 35%, going up to 0 to 50%. And a question was raised in a previous forum about, can you make that retroactive? And I think that would, if you've been providing insurance all this time and you meet those other criteria and you did not file for the tax credit, then it would be a good idea to visit your tax preparer and see if there is an option of amending your returns. I can't swear to you one way or the other how that works out, but if you're in that world, please check it out. And if you're in the world where you are going to provide insurance or wish you could afford it, then check out whether or not you're eligible for a tax credit. And then we get into the next category of businesses, and that is those with 50 or fewer FTEs, same FTE calculation. If you're in that market, then you are eligible to participate, then you are eligible to enroll in the marketplace or in SHOP. For the first year, for 2014, New Hampshire is using the federal marketplace, and for the first year, 2014, SHOP is open to businesses that employ 50 or fewer full-time equivalents, FTEs. And that is going to increase in 2016 up to 100 employees. And a couple of little things to remember is that employees are aggregated if you have multiple businesses that are owned or controlled by the same individual or individuals. Then those businesses are treated collectively as one in determining the number of employees. And that's pretty much it. Again, you will be able to enroll beginning October 1 right online, or you'll be able to work through an agent or a broker if that's what you've been doing all along. And there is online agent and broker training that is targeted very specifically to helping people navigate through the marketplace and through SHOP. So any brokers in the area, I know that I've got that website for where you can find that online training somewhere. So if you would like to have it and don't already know where it is, please check with me before we leave tonight and I can make sure that we get that to you. And the final category of employees is those with 50 or more full-time equivalents. You notice 50 is the lucky number this year. It's both in SHOP and in this final category. For those who are in the 50 or more FTE category, that's where we recently had a delay announced. It was announced in July, I believe, that there is a delay in the reporting requirements that go along with employer-sponsored health insurance. And because of the delay in those reporting requirements, the employer shared responsibility payment is also delayed out to 2014. Without the reporting worked out and without knowing what employer-sponsored plans are doing and what large employers are providing for their employees, there's no way to determine who might owe that shared responsibility payment, so it has been delayed while we work out the reporting requirements. So I don't spend nearly as much time talking about that potential shared responsibility payment as I otherwise might, because it has been put off for a year. Not because the payment wasn't the target of the delay, the reporting was the target of the delay, and you can't do one without the other. However, if you're in that category, this is all conditional, so pay attention to irs.gov or check and see what forums are going on this time next year, because then we'll have a much better idea of how the reporting and the shared responsibility payments are going to work. But the shared responsibility payments, if you're in that 50 or more full-time equivalents, the request or the ask or the determining factors are such employers are asked to provide, or at least consider providing, insurance to at least, or offer insurance to at least 95% of their full-time employees. There's no requirement to provide insurance. There's no expectation to offer it to part-time employees. But there is a component in there that it's been referred to as pay or play. Offer insurance to your full-time employees, at least 95% of your full-time employees, or there's a potential of having to make a shared responsibility payment somewhere on down the road. And there is an exception for seasonal employees, and we have a lot of those, and there's probably a fair number of folks in here who have seasonal employees. If you have a number of seasonal employees who are on board fewer than 120 days of the year, those employees will not be the piece, they will not be in the count that could kick you over or under that 50 count. Any seasonal employees who are on board for 120 or fewer days, you can exclude from your count and look only at those who are on board closer to year-round. The potential shared responsibility payment will vary according to whether or not you've offered coverage to your employees. If you are providing employee-sponsored health insurance to your employees, the potential for the shared responsibility payment will not kick in unless at least one of your employees is qualified through the marketplace to acquire insurance differently with a premium tax credit. And the only way that that happens is if the plan that you're providing doesn't provide the minimum value or isn't affordable. And affordable is a hard thing for an employer to figure out because affordable varies according to the household income of every employee. So rule of thumb is if the employee's out-of-pocket cost for those premiums is going to exceed 9.5% of what you pay them, then you might be in the not affordable category for that specific employee. And if that were to happen, then the shared responsibility payment would be $3,000 per employee receiving that premium. If you do not offer insurance, again, one of your employees would have to qualify for a premium tax credit in order for that shared responsibility payment to be triggered. If you don't offer insurance to any of your employees, if so much as one employee receives a premium tax credit, the shared responsibility payment is anticipated to be $2,000 per full-time employee minus the first 30. One person gets a premium tax credit, your full-time count minus the first 30, 2,000 times whatever that number is. That would be the shared responsibility payment. These are the things that I just really encourage people to check out the regs, check out the resources, and look into these things so that you can make a decision that's going to be the best for you and your employees in terms of what's the most affordable and allows you to do what you need to do as a small business owner and operator. And I'm probably running over time. So there are a lot of resources so that you don't have to actually remember what I've said because you can find anything that I've said online somewhere. SBA.gov/healthcare. We have our information broken out according to the different groups. Sole proprietorship, under 25, we've got the information kind of in the same order that I presented it today. Healthcare.gov is more global. So if you're an individual, which includes a sole proprietor with no employees, and it also includes anybody who's in a world where there is not employer-sponsored insurance. You're all individuals, so that information can be found at healthcare.gov. IRS.gov has the information about the tax credits, and again, the information is current and online at irs.gov because it's already been in effect since 2010, and their final rules on the increases in 2014 have already come out. Department of Labor, DOL.gov, has some information on health reform because there is an employer notice to employees requirement for you to give notice to your employees, and there are sample notices on DOL site that you can use or not use, your call, so long as you give notice to your employees that covers the basic things about whether or not you're offering insurance and where the employees can go, which really is direct them to the marketplace. There is also business.usa.gov, which if you're in business and you've never visited business.usa.gov, that's a collaboration of about 13 different federal entities to provide anything in the federal world that can be helpful to small businesses is on that website, and it recently launched its healthcare tab. So those resources are available to you. The marketplace and shop both have 800 numbers for customer assistance. So we'll do our best to, if we don't have the answer for you, to point you to the best resource for you. And with that, I'm going to pass it on. To you.
Thank you, and I am delighted to be here with the opportunity to talk to you about one small component, which is a component of the Affordable Care Act, which is expanded Medicaid. But first, I think we need to recognize how complicated this whole subject is. And if you need to take a deep breath, because I know I do. Okay. So the Affordable Care Act has a number of components to it, and one component is expanded Medicaid. Medicaid is simply public insurance for people whose income is insufficient to pay for health care. That's all it is. Currently, we have Medicaid, but it's only available to low-income children, their parents, pregnant women, and certain working adults with disabilities. The Supreme Court ruled that states can decide whether or not to offer this one component of the Affordable Care Act. If states do decide, and New Hampshire has not yet decided, if the states do decide to expand Medicaid, the eligibility would expand, and it would be determined by income alone. So any adult ages 19 to 64 with an income up to 138% of the federal poverty level would qualify. That works out to about, really roughly speaking, $15,000 annually for an individual, or $31,000 for a family of 4. In New Hampshire, that means that somewhere between 48,000 and 58,000 people would qualify. And we know that in this county and among my constituents, we have quite a few people who are working people who really would benefit from this program, this assistance. I'm also going to pause for just a minute and say that what I've learned about expanded Medicaid, I've learned because I'm on the Health and Human Services and Elderly Affairs Committee in the House of Representatives. And we have been so fortunate in having people come to us and present to us information about this topic. And I want to say that Deb Fournier, one of our next speaker, is one of the people who's presented to our committees a number of times, and she can help out with verifying any of these facts or explaining or whatever. And this is sort of a quiz for me to see if I've learned what I think I've learned. So
I'm keeping score right here.
okay, great. So carrying on, I guess this is an important issue for me because of issue of justice, fairness, and compassion. And this is the part that is really surprising to a lot of people. Under the Affordable Care Act, people with incomes above 100% of the poverty level, up to 400% of the poverty level, will get assistance with paying their premiums or get in the form of subsidies or whatever. But unless we expand Medicaid in New Hampshire, people with incomes below 100% of poverty level will not receive assistance. And that is because, as I said, the Medicaid expansion was a component of an entire system in the Affordable Care Act. And now that that's optional, if we choose not to expand, that will leave a significant group of our people without assistance. And of course, that would severely impact their ability to get health care. And I will pause for a minute too and remind us that when you don't have adequate health care and your health suffers and you have an illness and you don't get care, the consequences can be very, very serious. And they're not just physically serious, they're consequences as to how well you're able to take care of your family, how well you're able to earn your income, and there are also costs that are passed on to other people. And we'll go into that in a minute. So where are we in New Hampshire now with expanded Medicaid? One of the first things that happened in January this past year was a bill was brought forward, HB 271, which is an act stating that New Hampshire will not accept Medicaid. So sometimes things get a little confusing in Concord when you're voting for something that's a negative. So our committee heard from about 45 to 50 business people, representatives from insurance companies, hospitals, physicians, nurses, people suffering from substance use disorders, people treating those people, as well as many other people. And overwhelmingly, they asked us to increase the number of individuals with health care coverage. They're also asking us to do this, and by doing this, to bring hundreds of millions of federal dollars to the state. The committee voted inexpedient to legislate, which means they did not want to accept the bill to not accept expanded Medicaid. Sorry about that. And that vote was upheld by the House, which means that not that we are going to have expanded Medicaid, but that the door is still open to discuss expanded Medicaid. So that was our first step this year. Next, the budget bills, HB 1 and HB 2. Governor Johansson and the House both included Medicaid expansion in their versions of the state budget. However, the Senate did not. So what happens when there's a disagreement in that case, or things don't line up just the same, is that a committee of conference is appointed to reconcile the differences. When they attempted to reconcile those differences, or did reconcile them, there was no provision to spend money on or to accept money for expanded Medicaid. Instead, what they did was establish a commission to study the expansion of Medicaid eligibility. So that commission has been meeting regularly, I think weekly, since July, I believe, and continues to meet, and they're now stepping it up to twice a week. They've heard from the same professionals, the same experts, plus more, and they are charged with filing a report and a recommendation by October 15th. At that time, we're assured that the governor will call for a special session for the House and the Senate to vote on it. So we know that Medicaid is a public insurance program for people who cannot afford their health care. Under the provisions of the expanded Medicaid program, the federal government would pay 100% of the costs for all newly eligible people from 2014 to 2016. So the people who are currently on Medicaid, the government pays a certain percentage, it's not 100%, and they would continue paying the same amount or whatever the negotiated amount is for those people. So for the newly eligible people, the federal government would be paying 100%. And that federal support does gradually decrease, but it is indeed a very gradual decrease. It's not a huge decline, so that by 2020, the federal share would be 90%. And that's where it stays unless Congress acts. And I will point out that in the past, Congress has never reneged on its agreement to pay its share of the Medicaid costs. Also, if at any time New Hampshire decides that they would not like to be involved in expanded Medicaid, they can pull out. So if for some reason the federal government said, oh, no, we're not going to pay 90%, we're only going to pay 89%, and we found that unacceptable, we could withdraw from the program. We could stop offering that health insurance program. So, what would the financial impact be on New Hampshire? There would be a net increase in the cost, Medicaid costs, to New Hampshire in the fiscal years from 2014 to 2020, but that cost would be $18 million. $18 million sounds like a lot of money, but hold on just a minute, because providing Medicare coverage would reduce other state costs and increase revenues by $64 million. So the net savings to the state's general fund would be $45 million. And I'm going to ask Deb to correct me if I've made any errors on that.
A+.
Okay, great. So that's great. We can continue. All right. Another question that comes up is, what would the effect on commercial insurance premiums be? Currently, as most of us know, premiums are rising. And that is due to a lot of different factors, including the increase in medical costs, but not necessarily because we're using more health care. Expanding Medicaid may improve the average health status in the commercial insurance risk pool by reducing the number of people of lower socioeconomic status who are not receiving adequate care now and whose costs are more expensive. So it is quite possible that this will, I'm not going to say it's going to make insurance premiums better, but it won't be a terrific negative impact on insurance premiums. It also will help some employers because if their employees are on this expanded Medicaid program, then the employers can avoid the penalties for not expanding their coverage. Some people have expressed some concerns about, and we were informed about, questions about access to care. And Mr. McKinnon did a good job of telling us how we're preparing in this county to address that. We also expect that prevention and early treatment, because you have to remember that the people who would be eligible for this program are not generally getting adequate care. Some people are using the emergency room, which is a very expensive way to do it, but many, many people are just not getting care at all. So prevention and early treatment would reduce strains on more resource-intensive emergency services. Also, other improvements are currently being made, and Mr. McKinnon mentioned some of them, that are helping to improve our capacity, increase our capacity. So we're preparing to have adequate access availability. Sorry for the awkwardness in trying to express that. I also want to say that the Expanded Medicaid Study Commission has more than just two options. They can decide to recommend expansion, or they can decide to recommend against expansion, but they can also suggest alternatives. And one alternative that's being considered is the Health Insurance Premium Assistance Program. And what this would do would keep low-income workers on their private insurance with their at the commercial rates. But if it was less expensive for the state to assist with those premiums than it would be to put them on the full-blown expanded Medicaid program, in those cases, they would be able to make the less expensive choice, and the individual would stay on the private insurance that they still have. So that's up in the air now, and hopefully, well, definitely by October 15th, a recommendation will be made. So in summary, Medicaid is a public insurance program for people whose income is insufficient to pay for health care. Without expansion, people with lower incomes will not receive assistance in obtaining health insurance, while people with greater incomes will. Expanding Medicaid will net significant savings to the state general fund, and we do expect to have the capacity to deal with more people receiving health care. So thank you, and pass on to Deb Fournier.
So I have a bazillion slides, but we're not going to go. Okay. Okay. So I thought we would just get right to the what do I need to worry about and when do I need to start worrying about it part. And if you want to talk about the overall structure of the Affordable Care Act and all of its components and how the Congressional Budget Office scored it in terms of how it affects the deficit, we can do all of that in the question and answer time. But what I really want you to walk away with is to remember October 1st of this year and January 1st of next year if you're an individual. And if you are an employer with 50 or more full-time employees, I want you to think about January 1st next year, 2015, okay? So what we're going to talk about right now are the marketplaces, the individual mandate, and then consumer protection. So things that were changed about how insurance is regulated to prevent some of the insurance market behavior that people found the most offensive. Okay, so the marketplaces, let's go first. So the marketplace is, it's going to be an online portal. Did anybody shop for your airfare online? It's Expedia.com for health insurance. If you are buying insurance for yourself as an individual, or as Greta was saying, if you have a small business, if you have 50 or fewer businesses, you can shop in the shop. What does that stand for, Greta? S-H-O-P.
Small Business Health Options
From, yeah, okay, shop. So if you have a small business and you want to go to the Expedia.com for your business, shop. If you're an individual and you are trying to buy insurance on your own, go to the marketplace, okay? So what happens there is a few things. One is that you get a standardized view of the insurance products that are going to be available. Okay, so you'll be able to make an apples-to-apples comparison. So you'll see products in the same price point that they all have to have a standardized list of benefits. Some will have more, but they all have to have like the same floor, right? Those are called essential health benefits. We'll talk about those more in a moment. And anybody can shop in the marketplace. But what's special about them is that those tax credits that Greta was talking about are only available if you buy your health insurance through the marketplace. Okay, even if you're in the income eligible range, if you don't buy it through there, you cannot get those tax credits. Okay? So, and that the insurance sold there will have to meet these essential health benefit requirements, which means that basically there's a certain number of categories that every health insurance policy in that marketplace will have to contain. And they'll have to be fleshed out, meaning certain services will have to be provided within each category according to decisions that the state's made about what it thinks is appropriate. Okay? That portal opens on October 1st, so less than 30 days. You can go to healthcare.gov right now, today, and you type in, looking for help for individuals and families, and you put in your name and your area code, your zip code, and it'll ask you questions about work, insurance available, etc. And then it'll tell you, come back on October 1st, and when you come back, bring these documents with you to help you shop for what you're going to need. And it's probably things like your W-2 and your tax returns from last year. Okay? Okay, so that's why October 1st for this year is important, because that's when open enrollment begins. When you go to the marketplace, like I said, these are the categories of services that have to be offered in every health insurance product that's offered there. Now, we have chosen an insurance policy as a benchmark to say what the minimums within each of those categories is. Because, for example, if you just say maternity and newborn care, technically, the way lawyers think, maternity care could just be delivery and taking care of the baby for 36 hours, right? Like, that could be what it is. It's not what it is, but it could be. So the way that we've chosen to flesh out all those categories is in this health plan called Matthew Thornton Blue plan. If you go to the New Hampshire Insurance Department, NHID.gov, I think, website, you can look up the Matthew Thornton plan and see what the benchmark is. Okay? Now, the part that everybody really wants to know is what do those tax credits do for me? Okay, so this chart approximates an individual's income, and it looks at what share of someone's income they will have to pay towards their premium if they shop in the marketplace, okay? And so the percentage of premium that you are the percentage of your income that you will have to pay towards your premium is on a sliding scale depending on what your income is. And the lower it is, the lower the percentages, and the higher it is, the higher the percentages. And then it tops out at 9.5% for people at 400% of the federal poverty level. And for people over 400% of the federal poverty level, there's no assistance, there's no financial assistance for you. You can shop in the marketplace, but you won't get a tax credit. And as the representative was saying, if you have income under 100% of the federal poverty level, because of a tick in the law, the way the Supreme Court decision came down, the subsidies in the statute aren't available for people with incomes that low because the Medicaid expansion had been mandatory when the law was originally crafted. and they didn't imagine that that would become optional. Okay, so the advanced premium tax credits pay the remainder of the premium cost. So if I make $23,000 a year, right, and I'm here, I don't pay any more than, what, $1,400 a year towards the premium, even if I get like a $6,000 or a $10,000 policy on in Marketplace. And then the advanced premium tax credit pays the rest of that. Got it? Understand, basically? Okay, good. All right, let's move on. So what can you get? Like, how are there different options in the marketplace if there's only one carrier, right? So Anthem is the carrier who's going to offer products, they're called qualified health plans, right, in the marketplace. But there has to be products offered in each of these metal categories, okay? And these metal categories are organized by something that insurance nerds call actuarial value. Okay, it's expressed as a percentage, and what it means is the percentage of the cost of the coverage that you are likely to get that the plan pays for. So the lower the actuarial value, the lower your premium, but the higher your out-of-pocket cost. Okay, so if you are looking for something to fit your budget, and a monthly premium probably isn't going to do it for you, then the bronze plan is going to have the bare bones of those essential health benefits, and it's going to have low monthly premium, right? But it's going to have higher out-of-pocket costs, higher cost sharing. And then the arrows go like this, right? So if you get the platinum plan, it has a higher premium, but the out-of-pocket is lower. So depending on your healthcare needs, right? If you're relatively healthy and you're in that first low-paying job, maybe you want the bronze plan because your premium tax credit is going to defray most of that cost, and you don't want a monthly bill, and you think you're probably never going to the doctor, so you won't ever have to pay the out-of-pocket stuff, right? Or, if, on the other hand, if you have a serious health condition and you need to go to the doctor all the time, and you don't want a lot of co-pays, and you can, you know, maybe the premium tax credit makes the platinum more affordable, then maybe you go with that. Does that make sense? Anthem has to offer products within each of these, multiple products, within each of these categories. Even though they're just one carrier, they have to fill all of those, they have to populate all of those different needs. There is, I have heard the same thing, Harvard Pilgrim is expected to get in 2015, and hopefully we'll have many more carriers I'm going as fast as I can, in the marketplace in the coming years, because the hope is, right, that the more carriers there are, the more they have to compete, and the price points get better for the people purchasing the products. Okay, so that's explaining actuarial value. So how do you get one of those? Well, you have to submit an application to the marketplace to buy your health insurance, right? So, and the tax credit can be taken two ways. You can take it as a credit against your taxes next year, so you'd have to project your income, right? But then it's automatically exchanged as between the health plan and the treasury, and so you don't have to do any transaction with them, right? And then whatever the difference is, you pay for premium and the cost sharing. Or you say, no, like, I'll pay it at tax time next year, I'll pay full freight for my premium now, and then I'll get whatever the value was of that advanced premium tax credit applied to my tax liability next year. Right, so it would come out of whatever your federal income tax return will be. So also in the marketplace, there will be protections for out-of-pocket spending, out-of-pocket limits, right? And so in insurance world, there's premiums and then there's cost sharing, and those are different things, right? So now I'm talking about, you know, we're talking about the advanced premium tax credits for helping to defray the cost of the monthly bill you get for paying your premium. Out-of-pocket limits are about cost sharing, deductibles, co-pays, co-insurance, okay? So in addition to the premium tax credits, there's also protection for out-of-pocket limits. Now this is the limit. That doesn't mean you have to spend up to that. It means that individuals and families, again, on a graduated scale, depending on how far up the income level you go, cannot be forced to pay more than these levels out of pocket if you shop in the marketplace. But there's more. For folks at the very, very low income levels, so folks up to 250% of federal poverty level. So for an individual, that's probably someone making around $25,000, I think. If they enroll in a silver plan, so not the lowest priced plan, but the next lowest priced plan, they will be eligible for additional cost-sharing reductions, okay? And the consumer won't have to keep track of that. The feds will pay it directly to the insurance plan. And this is what, for example, it could look like. So for someone who qualifies for the cost-sharing reductions, they go from having a $2,000 deductible in the standard silver plan to having no deductible, right? And out of pocket for inpatient being admitted is a percentage point of what it would have been, or 10% of what it would have been under the standard plan, right? But, so those are only for people at those very, very lowest income limits. The Affordable Care Act, there is a little rhyme to its reason, right? People at the lowest income levels are the hardest to insure because affordability is the dominant lure into the health insurance market, absent a healthcare need, right? So if people are well, but they're busting their hump making $7.25 an hour, they don't make $16,000 a year. They don't have extra to spend on health insurance. So the Affordable Care Act deliberately designed a bunch of financial assistance at the bottom ends of the income range to give people financial assistance to draw them into and keep them in the insurance market. It's also why the Medicaid expansion was planned the way it was, because people with incomes below 100% are absolutely the hardest people to insure for that very same reason. Now, the Affordable Care Act doesn't solve the problem of there's no rate setting, right? There's no cap on premiums. It's not a law that says health insurance will never be more than this price. It doesn't say providers cannot charge more than this for these select services. It doesn't do that, right? But it attempts to give financial assistance to the people at the lowest ends. But, you know, admittedly, for people at the upper ends of income range, there isn't a lot of assistance, right? Okay. The individual mandate. This is the requirement that you acquire, I like that verb, acquire health insurance that Greta used, by beginning January 1st, that you get health insurance, or in the next tax year you pay a penalty. Okay? So if you are uninsured for less than 3 months, the penalty will not apply to you. If the insurance available to you is more than 8% of your household income, it is deemed unaffordable under the terms of the law, and you will not be fined a penalty. It doesn't give you insurance, but it exempts you from having to pay. There are, again, as Greta said, there are religious exemptions that can apply, and the penalty is going to be gradually introduced to the public. In the first year, it will be $95 or 1% of the household income, whichever is greater, and then gradually it'll phase up to $695 or 2.5% of income by 2016, whichever is greater. Okay, so that begins January 1st. That is not levied until the following tax year. The individual mandate will be a transaction that's levied through the federal income tax system, which is why if people have income so low that they are not required to file a federal income tax return, they are exempt from the individual mandate because there wouldn't be a way to find them or capture them, since it's going to be done through the income tax process. Right, and there's no criminal penalties. When I first started doing this presentation, people worried about stuff like this with me. Right, it's just traditional civil penalties for not paying the individual, like any other tax penalty. Okay, so you heard a lot about employer responsibility. This is the big one. Again, it's not going into effect until 2015, but this is my favorite way for looking at it. If you have 50 or more full-time employees, and you can talk to Greta about how that gets calculated, I am sure there's a whole cottage industry of lawyers and accountants who are going to help people figure out who is 50 full-time employees and who is not. But if you have 50 or more full-time employees, right, then there's the potential for financial exposure if a few things happen. One is you either don't offer your full-time employees insurance, or the insurance you offer to them is considered unaffordable, which means it is more than 9.5% of their household income, okay? Or it doesn't cover some of the minimum value of what the Affordable Care Act considers essential coverage, okay? If those things happen, and then one of your employees goes and accesses a premium tax credit in the marketplace, then, and only then, will potential penalties apply. And they're different depending on what the employer didn't do. If they didn't offer coverage, it's $2,000 per employee, per full-time employee, minus the first 30. Or if you did offer but it was unaffordable, then it's $3,000 for every employee that gets an advanced premium tax credit. So it's handed out differently depending on what the employer did and didn't do. But remember, so you have to, the employer has to be of the appropriate size, and then they either have to have insurance that didn't meet some of those standards, or they didn't offer it at all, and then someone went and got a tax credit on in the marketplace. Okay. There's other things that employers are going to be responsible for. Employers are now required to offer employees who are nursing reasonable break time to express milk. Now, reasonable, I think it's going to be sort of adjudicated along the lines of reasonable accommodation standard language. What's, an undue burden on the employer given the circumstances, et cetera, et cetera. But that's current on the books right now. And then there are other notice requirements. I think a lot of you already know about this. The value of the health insurance provided to employees has to now be reported as part of on their W-2 forms, right? And notice requirements will occur that Greta was talking about employees being eligible for potential financial assistance, and what happens if they don't have it, et cetera, right? And then employers generally need to be aware of the other reforms that happen to flex savings, health savings accounts, things that employers traditionally offer as benefits, so they make the appropriate changes to whatever products they offer to their employees. So then there's the consumer protections. These will also kick in on January 1st of 2014. Okay? Those are in green. And they're going to join the ones that are already on the books, which are the ones in gray. Right? So the most popular one that people are talking about is this one here, right? People love that one. That's been on the books since 2010. People being able to keep their adult children on their policy until they turn 26. And then the things that we think are really inexcusable, like rescission is the fancy word for kicking people off of insurance when they get sick, but saying that it's because they committed fraud 3 years ago when they didn't report they had acne and now they have skin cancer, right? That's but not been permissible for a few years now. And then things like no lifetime limits if someone's very sick, they can't max out their insurance policy anymore. And we haven't allowed insurance companies to exclude coverage for kids based on pre-existing conditions. And then adults get to enjoy some of those protections now starting in January of next year. And the community, I want to point you to some things. The community rating and guaranteed issue are the flip side of the individual mandate. Right, so the individual mandate is the attempt to get more people into the private market, into the private insurance market as possible, right? And sort of in exchange for saying, okay, we're going to give people a financial disincentive for remaining uninsured, which we're going to try and shoulder people into the insurance market. In exchange, insurance industry, you're going to have to accept anybody that shows up at your door. That's what guaranteed issue means. Someone shows up with both arms barely hanging on, looking like Bill the Cat, they have to sell you health insurance, even if you look like a terrible risk, right? And community rating is when the rating variables of how much you can mark up someone's health insurance policy is done across a community basis and not as widely as it is now. And generally, the variables are going to be limited to age, which is permissible now, but now there's no limit really on what the age rating difference can be, right? And now age rating will be allowed at 3 to 1, which sounds outrageous if you're 60, right? But it's better than it being 20 to 1. And geographic area and family makeup and tobacco use are generally the things that will be allowed for variables for pricing insurance for someone. And the biggest one, obviously, people won't be able to be excluded because of a pre-existing health condition. So the people who need health insurance will be able to buy health insurance. And perhaps it will be more affordable than it is now. Right? Okay. How are we doing on time? Good? Okay, so do you guys want to talk more about the Medicaid expansion, or do you want to talk more about sort of the overall makeup of the Affordable Care Act, like how it's paid for, or do you want to stop and just do questions? Questions? Okay. Thank you very much.
So for questions, here's what we're going to do. We're going to actually use this wireless microphone for you all asking questions. If panelists either say we are, it's fine. We have wired microphones for the responses, and I'll plug those in a second. So, Janice, were you going to come do this, or do you want me to actually be the question walker around her?
I'm happy to be the question walker around her.
All right, so Janice is going to do that for us.
It's my exercise.
All right. So the way to do this is, if you have a question, why don't you put your hand up, just like in grade school, Janice will come around, and if you ask the question, articulate it as briefly as possible. If you know for sure you want one of the panelists to answer, maybe address it to them. If you don't know who might be the best person to respond, you can just sort of ask it open-ended, and they'll figure that out, we'll figure that out. If you took the time to write a question down on note paper, you can just put your hand up and just hand it to us, and we'll read it off in case you don't want to do that. Sound all right? So go ahead and put your hands up for questions. Janice, you can take that.
Perhaps it's for Susan, the question. If you are concerned about social justice and you want to have your voice heard and encourage those in power to expand the Medicaid portion of this act, what can you do?
Thank you. The decision points are the Commission to Study Medicaid Expansion will be making its decision by October 15. You can find the names of those commissioner members by going to the General Court, New Hampshire General Court website, and there will be a link there to the Commission's website, which I believe is housed at the Department of Health and Human Services. So you could express your opinion to those people. Then I believe that the House of Representatives will be considering this later in the fall, and you could certainly contact your state representatives, and also the Senate should be doing the same. And I think maybe just also raising awareness among other people in the general public who may not be aware of the situation would be a good way to go about it.
I have 3 questions. 2 of them are very brief. You mentioned that there's an open enrollment. I assume that there's no end date, but is there an end date? And what is the online portal address for? And then the final question is has to do with a lot of small business people, and in this valley there are a lot of small business people, and a lot of them have big deductible plans. And I assume that in the portal that they're going to continue to have a big deductible plan. And one of the benefits of an insurance company is that they can negotiate lower costs. But when you have a big deductible, sometimes you go to the doctor or you go to the emergency room and you just use your credit card or your debit card or whatever. Is there anything in the Affordable Care Act or maybe Medicaid expansion, I don't know where it would be, but to address the fact that some people end up paying, when they're paying out of pocket, a higher amount than the insurance company is going to pay or Medicare pays?
Can anyone hear me? Okay, I can talk loud. Okay, we got 2.
Battling. Okay, real quick, before I pass this on, because I think you have better info on some of it than I do. The open enrollment period is October 1 through March 31st. After that, there will be an open enrollment every fall, beginning October 15th. I can't remember the end date, but there'll be a window every fall. any of those time periods where we don't have open enrollment, if you have some life-changing event, such as loss of the coverage that you have through loss of a job, or passing that 26 years, or any of those kinds of things that might change your coverage, then you could qualify for enrollment during that off period. But the initial open enrollment is October 1 through the end of March. The website is www.healthcare.gov. The next part of your question that had to do with small business, you would think I'd be able to speak to, but it got a little bit more complicated than I think I can, so I'm going to give you first dibs.
So, a few things, right? So there is the out-of-pocket cost-sharing protections in the marketplace. So, and like I said, depending on the metal tier of plan that someone buys, they can manage how much out-of-pocket they want to spend, right? So that's the first option. The second thing is there is an insurance market reform called medical loss ratios, and that's expressed as a percentage, and that's basically this, that an insurance company has to spend a certain percentage of the premium dollars they receive on medical care. And if they don't, then they have to send a refund to their enrollees. And so it's 85-15 and 80-20 depending on the size of the insurer. And those reforms went into effect in 2010, but our insurance market, we were granted sort of a gradual waiver. So I think that the medical loss ratio is just now coming online in New Hampshire. But most importantly, there is an out-of-pocket limit in marketplace products. And in addition to that, a person can manage what their out-of-pocket is if they don't want a big deductible, depending on which metal tier they purchase in. And again, it doesn't, I wish it did, take away all the financial hardship for people to purchase and get health care when they need it. It doesn't do that, but I think it gives people options. So they can try to decide, would they rather have a big premium and no out-of-pocket, or a lower premium and deal with the out-of-pocket if and when they need to.
Did that answer your question?
Not really.
Yeah, I think what she was asking is if Anthem has been able to negotiate that blood work is going to be $100, but she
I go and I pay
she goes and pays $150, is there anything that's going to help that? Okay.
Can we change it?
So this might be a silly question, but for a nonprofit with less than 25 FTEs, when you talk about offering insurance, does that mean the employer is actually paying a portion of it, or you're just giving them the option to buy in themselves to the plan that we're offering?
For the primary issue that I've done my best to study up on for nonprofits with fewer than 25 employees has to do with the premium tax credits. I mean, has to do with the employer tax credits. And the requirements, the three primary requirements are fewer than 25, average wages below 50,000, and that the employer, the nonprofit entity, is covering 50% or more of the premium costs on behalf of the employees. And that assessment is based on the cost of a self-only plan. You may be offering a self and family, but you only need to look at the self-only cost of those premiums. If the employer is providing, or could afford to provide 50% in the face of a tax credit, then that's what we're looking for.
So if we don't pay 50%, we won't get the tax credit?
Correct. But look for the tax credit because it could make the difference in what you can afford to cover. There's no requirement that an employer cover any percentage of an employee's plan. That only comes into play when you look at affordability and risks of employer shared responsibility payments or eligibility for tax credits.
Another clarification perhaps to your question is, if you have insurance and you have a high deductible, the price of the blood work that Anthem would pay is what's going to go against your deductible. Between you and I, we'd rather have the higher price go so we can get to our deductible faster, but yeah. Okay, Next.
It's kind of similar to her question, but we have 50 or more employees. And so I'm not understanding what my responsibility is as the employer. I know that we have to offer the affordable insurance and that they cannot pay more than 9.5% of their annual income. But who pays the rest of that premium? Do I as the employer?
No, if you make that decision to offer the insurance, you determine how much of that premium you can afford to pay. And the employees pay the rest of that cost. Whether that's split 50-50, whether 50% of that cost is too much and you need to contribute less, or whether you can contribute more, that's a business by business decision. Your decision would be to take a look at whatever the employee is going to have to cover for the rest of that cost. Compare that to their earnings. And if their premium cost is going to exceed 9.5% of what you pay them, then that's how you can do a real quick, rough estimate of whether or not you might be subject to a shared responsibility payment, because that'll give you a rough idea of whether or not they might be eligible for premium tax credit.
Hello, welcome to Lost in Movies. I'm Alec Kerr, the film critic for the Conway Daily Sun. This week I'm joined by
Ashley.
And we are reviewing The World's End, the third film in the Cornetto trilogy, written and directed by Edgar Wright with Simon Pegg and starring Simon Pegg and Nick